All right, welcome. Today we're going to break down one of the most useful tools you'll have in your clinical toolbox for assessing acute ankle injuries. We're talking about the Ottawa Ankle Rules. So let's dive right in. Picture this. A patient walks into your clinic, limps in, with a fresh ankle injury. It's swollen, it's painful, and you have to answer the big question, do we need to send them for an x-ray? And here's why that question is so important. Research has shown that less than 15% of patients who actually get an x-ray for an ankle injury have a fracture. Think about that. That's a huge number of unnecessary x-rays. So here's how we're going to tackle this. First, we'll look at the dilemma itself. Then we'll introduce the solution, the Ottawa Ankle Rules. We'll go step by step through how to use them, and finally, we'll talk about just how effective they are and where their limits are. You see, for any clinician, it's a real tightrope walk. You want to avoid wasting time, money, and exposing patients to radiation they don't need, but at the same time, you absolutely cannot afford to miss a fracture. And this is exactly where the Ottawa Ankle Rules come into play. They're not just a good idea, they're a validated, evidence-based clinical decision rule designed to solve this exact problem. To put it simply, their main purpose isn't really to find fractures. It's to help you safely and accurately figure out who doesn't need an x-ray. Think of it as a tool for ruling things out. And the beautiful thing is, the whole process boils down to just two core parts of your physical exam. It's all about checking for bony tenderness in very specific places and seeing if the patient can bear weight. Let's start with the tenderness part. First up, we're going to assess some key spots around the malleoli. You know, those big bony bumps on each side of the ankle. This is what we call the malleolar zone. So what you're going to do is carefully feel along the back edge of the bottom 6 centimeters of both malleoli, and right on the very tip. That's the lateral malleolus on the outside of the ankle and the medial one on the inside. If you press there and the patient has pain, that's a positive sign. That points toward needing an x-ray. Okay, but we're not done with palpation yet. The rules don't just cover the ankle joint. We also have to move down and check the midfoot. This helps build the complete clinical picture. And here, you're checking for tenderness at two very specific spots. First, the base of the 5th metatarsal. That's that bony bump on the outside edge of the foot. And second, the navicular bone, which is on the inside just in front of that medial malleolus. All right, so let's say you've checked all 4 of those bony spots, and nothing. No tenderness at any of them. Now we can move on to the final part of the test, which is all about function. Can they actually take a load on that foot? The rule is pretty specific. An x-ray is indicated if the patient is unable to take 4 steps in total, and that includes limping. But, and this is a huge but, there's a major clinical caveat here where you really need to use your brain and your eyes, and this right here illustrates that pitfall perfectly. This is a real patient who said they could technically take a few steps, but they did it by shifting all their weight to the inside of their foot to avoid putting any pressure on a fracture on the outside. So here's the crucial takeaway. It's not just about them taking 4 steps. You have to watch them and use your clinical judgment. Are they truly weight-bearing through the injured area, or are they just compensating? Because just compensating doesn't count. Okay, let's put it all together. It's really a simple process. Is there pain in the malleolar zone? Yes or no? Is there pain in the midfoot zone? Yes or no? Are they unable to bear weight correctly? Yes or no? If you get a yes to any of those, you send them for an x-ray. If it's a no to all 3, you can be very, very confident that there's no fracture. So, we know how to use them, but the big question remains, how well do they actually work in a real busy clinic? Let's look at the evidence. And this is where it gets incredibly impressive. A massive meta-analysis that looked at over 15,000 patients found that the rules are almost 98% sensitive. What does that mean? It means they catch nearly all clinically significant fractures. They almost never miss one. And this just confirms that they are amazing at their main job, which is to safely cut down on all those unnecessary x-rays, saving time, money, and reducing radiation exposure for our patients. Now, this is a really critical point to understand. A positive result on the rules tells you that you need to look for a fracture with an x-ray. It does not mean a fracture is definitely there. Remember that first stat? High sensitivity often means lower specificity. So let's wrap this up. What should you take away from all this? The Ottawa Ankle Rules are an incredibly powerful, evidence-based screening tool. Their main job is to rule out fractures. but they are an aid to your clinical reasoning, not a replacement for it, especially when it comes to that weight-bearing test. And that kind of leaves us with a final thought, right? Being a great clinician isn't just about knowing the rules. It's about knowing how and when to apply them with thought and care. Even the best tool in the world still needs a sharp, skilled person to use it correctly.